Good afternoon to everybody, and thank you. It's always a pleasure to give this talk in Sleep in Children in the Fellows track. And this year, I'm the designated closer. So I just want to share that we actually moved to our new home. So we have a brand new children's hospital facility. We opened in October 17. And of course, New York was the epicenter of COVID, and a lot of our pediatric floor was turned into COVID units, and we admitted patients until 30 years of age. I have no disclosures related to this talk. You can see that my presentation included many slides. Most of that I shared because there are good resources for you to always go back if you have any questions about categories or about cutoff values. We'll try to contain the talk for kind of good discussion on comprehensive pediatric sleep review. So the objectives of my talk is that we want to describe the developmental sleep patterns from infancy through adolescent. We will review sleep disordered breathing, and we'll summarize the approach to the evaluation and the diagnosis of sleep disordered breathing. So we know that a number of us have been and are interested in sleep medicine fellowship, and most of the programs are ACGME. It's a one-year fellowship, and for the most part, it's post-fellowship. So usually graduates from adult pulmonary, pediatric pulmonary, neurology, and recently also there's a number of residents or candidates fresh from residency who goes directly to sleep fellowship. So this year, of course, with the COVID time, almost all places are virtually interviewing, which is a challenge. So I put here the link to ACGME as far as the details for the sleep medicine fellowship. Most of my polling questions are not really related to the talk, but really more for polling about our population as the pediatric pulmonary interested in sleep medicine. So my first question is, what is your current subspecialty fellowship training? I know that there's only a few of us here. There's about, I think, 25 or 26. Okay, so I'm talking to colleagues, 100% of us in pediatric pulmonary fellowship training. And the second question is, does your current program have also a sleep medicine fellowship program? Okay, so about a third of you are from an institution offering at least a sleep medicine fellowship program, and half of you have a sleep medicine a pediatric program, so that's very good. Are you going to a sleep fellowship training after your current program? So about 15% of you are sure going to have this second subspecialty under your belt, and still a quarter are considering to go to sleep fellowship. It's a one-year fellowship. So we are going to talk about or answer the following questions on the talk. The why do we sleep? Why is it important? What's the role of sleep? Why are we addressing it? What are the complications of sleep deprivation and sleep fragmentation? The what, we're going to discuss the basics of sleep, physiology, the diagnosis from screening to that of testing, doing the sleep studies. The how are we managing the pediatric sleep disorders? And we'll kind of talk about the latest and evolving options of treatment. And then the last, which probably would be an added resource for you to review after the talk, are the special populations that have sleep issues. So why do we sleep? So wish we can all have a good night's sleep. So Rutch Chafin from the RNK scoring said that if sleep does not serve an absolute vital function, then it's the biggest mistake the evolutionary process ever made. So it's very important to know that there are indeed a good number of functions of sleep. And one of the more important ones that I want to share is neuroplasticity. So during sleep, as you can see on the picture here, I included that there is really a generation of a lot of the neurosynapses, and sleep is linked to memory and learning. And it's very interesting that there's this large epidemiologic study that was published in Pediatrics, that pediatric sleep disorders in the first year of life is associated with special education needs at 8 years of age. So it's really important, the impact of sleep in the developmental stage of an individual. So you can see here that there are definite recommended hours of sleep in children. And this was a consensus statement by the American Academy of Sleep Medicine that was immediately endorsed by the American Academy of Academy of Pediatrics. So you can see that sleep is really developmental. And, as a newborn, of course, you know that all they do is eat and sleep. So for the most part, apart from waking up to feed, they sleep, and it doesn't matter whether it's day or night. And you can see that the younger the patient, the more that they have a tendency to nap. However, when they start attending school after 5 years of age, their sleep becomes consolidated. So this is actually kind of a good education resource material that you can show to your patient, because it's kind of just a simplified graph showing that depending on the age group, these are the recommended amounts of sleep. And you can see here, even teenagers, which we know has had a lot of sleep challenges, really needed about 8 to 10 hours of sleep. Interestingly, when I ask my adolescents, how many hours of sleep do you really need? They know the answer. It's just that they really have a problem kind of staying on a routine. And we'll talk about adolescence and sleep too for a portion of the talk. So the adverse consequences and complications of sleep. Here you can see the categories, and they actually even correlate with the known complications of sleep deprivation in adults. So we have cardiovascular, including hypertension, pulmonary hypertension, core pulmonale, and endothelial dysfunction. In nutrition and metabolic, you can see that there's a spectrum. A patient could be on the obese side, or also as a consequence would have poor weight gain and failure to thrive. And then associated with sleep are also the metabolic syndrome derangements like insulin resistance and dyslipidemia. Nocturnal enuresis, and that's secondary enuresis, that means that they have been toilet trained for at least more than 6 months, and then they started bedwetting again. had been correlated with pediatric sleep disordered breathing. And of course, for the past 2 decades, there have really been enough research study and a link between poor sleep and neuropsychiatric complications. You can see here neurocognitive impairment, which could cause learning disabilities and developmental delay. And a good number of ADHD patients really have primarily sleep deprivation as their etiology. So hyperactivity, attention deficits, concentration problems, impulsivity. And then for older patients, you can see anxiety and depression could be associated with sleep disordered breathing. And excessive daytime sleepiness is more of a manifestation of adults than kids, although now we can see more and more in our obese population and the adolescent that they have daytime sleepiness. And in red here, of course, increased healthcare utilization is really considered as kind of a big impact and consequence of sleep. And in general, these are not just to the immediate sleep problem, but also carries into long-term health problems in adulthood. So we know that the American Academy of Pediatrics established a clinical practice guideline that would help primary pediatricians. And this was published in Pediatrics in 2012. Carol Marcus is the lead in this endeavor. And the Pediatrics in Review article last year actually have tabulated it. And let's just walk through about what are the main messages or points of the practice guideline. So all children and adolescents should be screened for snoring, and sleep studies should be performed for those with symptoms. If sleep study is not available, then consider an alternative diagnostic test or refer to a sleep specialist. Adenotonsillectomy is still the recommended first line of treatment. There are high-risk patients that should be monitored as inpatients post-operatively. We'll identify them. And patients should be re-evaluated post-operatively to determine when further treatment is required. So objective testing should be performed for those who have indications. So it doesn't mean that when you do a pre-operative sleep study that you have to have a post-operative study, but there are, of course, kind of high-risk patients or those with persistent symptoms that you need to consider this testing. CPAP, or continuous positive airway pressure, is recommended as treatment if surgery is not performed. Weight loss is recommended in addition to other patients in other therapy in patients who are overweight and obese. And you have medical management options like intranasal steroids for those with mild OSA after tonsillectomy, or those to start with have mild OSA that you want to avoid surgery. So let's talk about the basics of pediatric sleep disordered breathing. And this is actually a very simplified slide, but it really kind of sends the message that in terms of the mechanism of OSA, it's really a balance and maintenance of your airway patency. So on one end, there's upper airway narrowing, and on the other end is actually your upper airway collapsibility, or your, tendency to kind of compensate if there's any existing obstruction. So obesity and adenotonsillar hypertrophy are the biggest cause of your upper airway obstruction. And in terms of upper airway collapsibility, we have those patients that we can identify with decrease in muscle tone, like those with neuromuscular diseases and cerebral palsy. Airway inflammation, which is common in our practice, rhinitis, also leads to upper airway collapsibility. And you can see here, obesity actually can tip off, any points of these two main balance. Now, why are there some kids with seemingly big tonsils are able to compensate? Why? Because they have increased tone of their upper airway muscles that compensate for a narrow airway. So you can see here that the peak rate pressure is a pressure. Can you actually, I'm sorry, I have to move my screen. So you can see that peak rate is the pressure at which airway collapses. So peak rate is actually the pressure surrounding your upper airway, which is a collapsible segment. And the relation of the peak rate to that of your upstream segment, which is your nasal segment, to that of your downstream segment or your lower airway, your trachea, is very important or crucial to determine whether you have a patent airway, an occluded airway, or a flow-limited airway. So in any situation where your peak rate is actually more positive as opposed to your upstream and downstream pressure, then that leads to airway occlusion or flow limitation. And it is known that normal children are able to compensate and they're able to maintain airflow at subatmospheric pressure. But if you compare that with patients with OSA, their peak rate value is always on the positive range, so that it always ends up with some airflow limitation or airflow obstruction. So let's start with, of course, the most common cause of upper airway obstruction in children, which is adenotonsillar hypertrophy. Although this is very basic, it's worthwhile to review your grading of your tonsil size. So here you can see that tonsil size 0 means that there is, of course, a surgical removal of your tonsil. And the way that you grade your tonsils is really dropping kind of a line on the half of your pharyngeal view. And if the tonsillar tissue does not cross that midline, then it is +1. So it really occupies about 25% of your pharyngeal space. +2 is that if it meets that line that you drop on the midline. +3 if it actually extends, so it's about like 75%, greater than 50 to 75%. And of course, the +4 is where the tonsils are either kissing or touching the uvula. And you just imagine that with this enlargement, there's a lot of tissue vibration, thus the snoring sound and other heavy breathing. So this is another way to view it, and this is actually more practical because these are really actual kind of patient tissues. And again, grade 1 occupies less than 25%, 2 about more than 25 to 50%, grade 3 greater than 75%, and grade 4 occupies almost all of that space. Does your program or institution perform sleep endoscopy? Okay, so about 40% would have abilities to perform sleep endoscopy. So sleep endoscopy is actually good, and usually we partner with our ENT colleagues Just go back. Okay, so sleep endoscopy really identifies the problem in the upper airway if there is really no concern for enlargement of your tonsils and adenoids. So here you have a variety of example. You have here mostly the nasal turbinates that's enlarged, your adenoids relatively obstructing the airway. You can see a lot of inflammation surrounding your laryngeal inlet in this picture in this side. This one is an example of your laryngomalacia where your epiglottis is hooding your inlet. And this is a kind of a more open, normal laryngeal inlet. And a good example of sleep endoscopies for the younger population. And you can see here, this is an infant who underwent supraglottoplasty for laryngomalacia. And usually you can see that redundant tissue there and post-procedure after the laser. And sleep studies are helpful or useful to identify obstructive sleep apnea in this population and objectively measure the outcomes. So in this particular ENT publication, there's significant improvement in 70% of the sample size that they look in the apnea-hypopnea index, and even the oxygen saturation have significantly improved considering this procedure. Does your sleep program have a sleep center or a sleep lab? So I asked that question before going into the categories for the classification of OSA in children based on the apnea-hypopnea index. So you can see here in terms of the severity, there is really a big difference as far as the range for normal, mild, moderate, and severe. So you could actually underdiagnose your pediatric patient if you are using the adult severities criteria for the AHI index. That's why part of our roles as pediatric pulmonologists and pediatric sleep specialists is to kind of share and educate our adult colleagues who are also studying children in their sleep center or sleep laboratory. Now, in terms of the spectrum of pediatric obstructive sleep disordered breathing, you could have a range from one end, just habitual or primary snoring, to that of a full-blown or overt obstructive sleep apnea syndrome. So here in primary snoring, you can see that it occurs more than 3 nights per week without any obstructive events. So no associated apneas, hypopneas, arousals, or gas exchange abnormalities. And the prevalence of that is about 7% of the population. So you can see here that you have a nice airflow on your nasal pressure transducer. So you can actually measure airflow through the nasal pressure transducer or your thermistor. And these are the chest and the abdominal efforts. So you can see that the effort is synchronous. So primary snoring, you really only identify that vibration of the tissue. Next is upper airway resistance syndrome. And again, it's very important to kind of recognize that this entity exists, separate from a full-blown OSA syndrome. And again, without this knowledge, you might be underdiagnosing your patient. So in addition to snoring, you have increased work of breathing that leads to frequent arousals. But there are no recognizable apneas or hypopneas or any oxygen desaturations or CO2 abnormalities. So in this example, if you look at the flow, you have a regular airflow and then it starts airflow limitation. And there is a associated microarousals because of the feedback mechanism of that airflow limitation, and the patient would wake up and have go back to the normal airflow. Obstructive hypoventilation is the next spectrum, where you have, in addition to your snoring, just elevated CO2 levels without any recognizable apneas or hypopneas. So you can see here, again, if you look, there's seemingly airflow and good effort, although you might suspect that the airflow here would be more paradoxical. And it's important that you have this end-tidal CO2 monitoring, and you can see it's measuring above 50s, and you know that the usual acceptable range would be 35 to 45. Now, respiratory disturbance index is also good to identify and sort out, and this is actually a combination of your AHI, your apnea-hypopnea index, and your RERAS, which is your respiratory event-related arousals that we talk about for upper airway resistance syndrome. So in the AASM scoring manual, they recommend to really sum it up with RDI, because sometimes a patient might just have your more predominantly RERAS and obstructive hypoventilation. And again, you would be underdiagnosing these patients. For obstructive hypoventilation, we have two measurements. We could measure end-tidal CO2 through the nasal cannula, but you can see again, for kids, it might be difficult to maintain, especially for young children tolerating that. And there's also another form of measurement through the skin, the transcutaneous CO2 monitoring. You can see that it is an electrode that warms up the surface of the skin, and it picks up signal from the capillary blood that closely matches your arterial CO2 tension. So in terms of obstructive hypoventilation, again, in the severity criteria, kind of think of it in quartiles. So you have mild obstructive hypoventilation if you have an elevated CO2 level above 50, about 10 to 25% of the time. Moderate is 25 to 50%, and severe is greater than 50%. There are some patients who might just kind of hover on the high 40s, and if that exceeds more than 60% of your total sleep time, then that's considered obstructive hypoventilation. So even obstructive hypoventilation alone or isolated hypoventilation can result in disruption of your normal ventilation sleep patterns, and these are associated with neurocognitive deficits and cardiovascular morbidities. Hypoventilation is common in our children with Down syndrome and obese children. You can see that in terms of measuring your end-tidal CO2, the reading would be at the end of the plateau during the end of your exhalation cycle. Last but not the least would be your OSA syndrome, where you have recurrent events of partial or complete upper airway obstruction. So you can see here, there would be reduction of your airflow by at least 50%. So that's your obstructive hypopnea. And here are really your overt upper airway obstruction. And you can see that it is associated with desaturations and rise in your CO2. Now, central apneas, of course, is separate from our discussion from the obstructive sleep apnea syndrome, but central apnea are a real entity. Um, and in the obstructive sleep apnea world, we have to be careful that there are a good number of post-arousal sighs. So they are central apneas, but they are commonly seen following an arousal, and this is because of the Herring-Buer reflex. You know that there are stretch receptors on our bronchi, so that it avoids overinflation of the lung. So you have to be careful when you score your post-arousal size and not work up these children for central apnea etiologies. Now, on a normal, healthy children, how much central apnea is acceptable? Um, there are publications that would be helpful as a resource. Um, Here is a publication looking into the younger age group, preschool and early school age children, where they studied about 540 patients. So this table would be helpful to look at. So when you're interpreting your sleep study, how much central apnea you should not be concerned about, and not necessarily have the patient be worked up for other etiologies. And this is another good resource. They are little older articles, but still they're kind of very good kind of ranges. These studied 50 normal children and adolescents, and the age range would be 1 to 17 years of age. Now, David Gosal has proposed a classification of obstructive sleep apnea as being type 1, where it's associated with adenotonsillar hypertrophy, and type 2 are the obese children and adolescent. So it's very helpful to categorize them, very analogous to type 1 and type 2 diabetes, so that they really have kind of different approach to management. There is even a proposal for a type 3, wherein there's a variety of your craniofacial and neuromuscular disorders. Again, this is more kind of a specialized management. And we know for a fact that these syndromic patients, just looking at their anatomical features, you can really identify micrognathia, macroglossia, or a relatively large tongue because of the small upper airway space, and mid-face hypoplasia. Here at the bottom is a patient with Pierre-Robin sequence, and you can see the receded chin, and this patient really needed tracheostomy until to allow airway growth. Other alternatives would really be kind of a tongue suturing to avoid the tongue kind of falling in the upper airway. Now that we are in the epidemic of obesity, it is very important to know that there is really a significant kind of impact of being overweight and obese. So if you are overweight and obese, about 50% of this population would develop obstructive sleep apnea, as compared to only 6% of normal weight children. And every increase in your body mass index by 1 above the mean for age and sex increases the risk of developing your OSA by 12%. Now, this kind of diagram is really very important to drive the point that OSA and obesity feeds each other. So the two key issues that underpin the development of your OSA-related morbidities are really low-grade inflammation and increased oxidative stress. So in OSA, because you have the apneas, hypopneas that would lead to sleep fragmentation, that actually incites neurohormonal changes. And then the inflammatory cascade actually kind of goes downstream, and you can see that there are production of a number of pro-inflammatory mediators. And you have, again, swings of your oxygen saturation leading to intermittent hypoxia that would be oxidative stress, and again would lead to decreased nitric oxide and contributes more into your inflammatory pathway. Now, obesity can lead to OSA, and OSA also could lead to obesity, so it feeds each other. And you can see on the line of obesity, the metabolic syndrome derangement, including insulin-resistant hypertension and dyslipidemia, also involves your pro-inflammatory pathway. And there are indeed evidences of inflammation in OSA. So you can see that they were able to measure nasal nitric oxide, hydrogen peroxide in exhaled breath condensates, and a number of these pro-inflammatory cytokines. Even C-reactive protein is found to be increased in the OSA population, specifically those with neurocognitive defects. Now, you could actually conceptualize that obstructive sleep apnea is really a fight and flight phenomenon, because there is interruption of your sleep architecture with all the physiologic gas exchange that's happening. So you have this repetitive kind of fluctuation in your oxygen saturation, as well as episodic hypercapnia. And imagine also with the occlusion of your upper airway, there would be large kind of fluxes in your interthoracic pressure, leading to recurrent brain arousals. So what happens on an unaddressed or untreated obstructive sleep apnea, that induces a sustained activation of your sympathetic nervous system. So to put it in simpler terms, you have your stress hormones activated during exercise because it's needed. You needed blood flow, you needed increased heart rate in order to have increased cardiac output. You need increased blood glucose in your skeletal muscles. Your pupils dilate and intestinal muscle relax. So if you have a sustained activation of your sympathetic nervous system during sleep, then you can see that it really leads to the consequences or complications of sleep. Immune system, hypothalamus, glycemic control, reproductive system, even bone formation, blood pressure, and cardiac function. So somatic arousals, those kind of micro arousals that I showed you after airflow limitation equates to sympathetic tone. So sympathetic tone, you have manifestations of stress like increased heart rate, sweaty palms, and dry mouth. So now we kind of looked into a body sensation questionnaire. So the questions are really like, are your hands shaky? Or do you feel fainting? Do you have cold spells? And somatic syndromes, insomnias, anxiety, and stress are really common among sleep disordered patients. So this is a very simple tool, but it measures somatic arousals and correlates to your sympathetic tone. Further, our sleep fellows have also looked into heart rate variability, and it's actually measuring or calculating the time between your R spikes on your EKG tracing. And then again, just to summarize, if you have a high heart rate variability, that means that you are compensating well. It's an indication of a healthy autonomic and cardiovascular response. However, if you have chronicity of these events, every night is happening, then you get adapted to it and you have a low heart variability response. So that means that your sympathetic and parasympathetic nervous system are not properly coordinating. Now let's go to the neurocognitive and behavioral morbidities. So what are the probable mechanistic role? In the OSA and the obesity diagram, we actually said that neurohormonal changes could lead to inflammation. This study I just want to share because it's very fascinating. There's an MRI data that shows that there are greater activities in the regions of the brain implicated in cognitive control, in conflict monitoring, and attention for children with OSA. So they actually have to kind of work harder in certain regions of their brain in order to perform the same task. And another article that I want to share, which is already a Sentinel article, it was again conceptualized by David Gosal when he was in Tulane. He did a prospective study in first grade school children where he looked at the lowest performing, academic performing percent of the class. And he found out that OSA is disproportionately high when he screened them. And he screened those with big tonsils and adenoids. So he offered surgery, TNA, to the parents. So now there are parents who actually consented to the procedure, and there are parents who actually refused. So now he has a control group and the intervention group. And it's so simple, but it's fascinating that when he followed these children the following year, those who underwent surgery had significant academic improvement versus those who did not receive surgery. So now let's go to adolescents. And adolescence is really a very kind of very special group as far as sleep disturbance is concerned. Why? Because although we say that it really is the psychosocial pressure because of the bedtime autonomy, the academic pressure, of course, now with technology, screen time, and social networking, that they actually does not have adequate amount of sleep. They go late to bed. However, it's very important to remember that there is also the bioregulatory pressure. During the pubertal year, they are undergoing bodily changes and hormonal changes. So their sleep pressure rise is slowed and they have more tendency for a circadian phase delay. Now, top it with societal pressure for school start time, then actually they are kind of a good recipe for sleep disorders. So it's actually called the perfect storm. It actually relates that the maturation of your regulatory system with the combination of the psychosocial and societal pressures would actually lead to sleep problems. So it's 14% higher among students who sleep less than 7 hours on school night. Remember when we discussed about how many hours of sleep the adolescent age group? So it's usually ideally 8 to 10 hours of sleep. So it's our responsibility to make sure that we ask about sleep hygiene, media, and sleep, and also really advocate for them. There's a number of states now that really allowed the high school to have a later school time. Now we'll talk about management of pediatric OSA. So, of course, we heard about the childhood adenotonsillectomy or the CHAT study. Again, this was spearheaded by Carol Marcus, and it is the first ever randomized controlled trial to compare the surgery with watchful waiting. So it's a good study. It's close to 500 patients with age range 5 to 9 years of age. The primary outcome that they looked at is that of a neuropsychological testing. And so it's change in attention and executive function score. Their follow-up range is only 7 months. The primary outcome did not really differ significantly between the surgery group and the watchful waiting. However, the secondary outcomes, which included behavioral, quality of life, and the sleep study data, they are, and the symptoms, they actually are significantly better on the early surgery group. And last but not the least, when you look at their post-op sleep findings, there's normalization with 79% post-surgery as opposed to only 46% for watchful waiting. Now, interestingly, after that study, that randomized trial in 2013, there were a number of sub-analysis. And in 2015, they kind of looked at those who are on the watchful waiting category. The 42% that actually had resolution of their OSA really are the lower risk patients. They have lower apnea, hypopnea index to start with, and they are the not obese population. And only 15% of them really experience symptomatic resolution. So, you could actually kind of interpret the CHAT study with caution because in terms of the patients that were included in the study, it's a cleaner study. They did not include patients who are moderate to severe and also those with other comorbidities like ADHD. Now, we said in the clinic practice guidelines that adenotonsillectomy is still the first line of treatment. What is really the true percentage and the success rate for that? And recently looking at the studies, there's a multi-center retrospective study where they base it on a post-op sleep study. So is there improvement in the AHI? Only 30% improvement. And in smaller cohort studies, so here we have 12 school-age children. After TNA, about 2/3 normalized their sleep study. And in 23 preschool children, 3 years after TNA, similar, about 61% had normal sleep study. So, we also have to remember that there are complications of tonsillectomy and adenoidectomy. So we really are obligated to sit down and kind of talk to our parents about it, what to anticipate. And there are, interestingly, over 600,000 TNAs performed annually in the US. And you probably have a fair share of your patients having complications. Children with OSA appear to have more respiratory complications. And usually they are respiratory compromised because of their a good number of them are obese, and a good number of them are our patients with comorbidities like asthma and allergies and rhinitis. And secondary hemorrhage, post-op bleeding is also common. So what are the risk factors for persistent OSA after adenotonsillar surgery? So you can see the obese group, those to start with having severe OSA, an AHI of over 20, the older patients, asthma, the African American population, and history of prematurity. So what are the factors that might really explain why premature babies are at increased risk of obstructive sleep apnea? For a number of reasons. One, they are often associated with generalized muscle hypotonia, and they have atypical breathing pattern, and this leads to the development of mouth breathing and alteration in the anatomy of their upper airway. So they usually develop high and narrow hard palate. And these premature infants also have abnormalities with feeding functions. And so they are more prone to upper airway inflammation or also the effects of reflux and aspiration. And also there's weakness of their orofacial muscles, which would negatively alter the growth of their upper airway, leading to a more crowded small upper airway. And also epidemiologically, if you look, a good number of premature babies end up with a higher risk of obesity at a later age. Now let's talk about medical management. We know that intranasal steroids and leukotriene antagonists or Montelukast, are recommended as part of your medical management short of surgery or post-surgery, just to show that when they look at the tissues of OSA patients, there are increased levels of pro-inflammatory cytokines. And actually, when they did in vitro experiments and put corticosteroids on these tissues, they have decreased proliferations and apoptosis and reduction of these cytokines. And clinically, when they did a randomized, so it's a big study, a randomized crossover trial of intranasal steroid for mild OSA, with at least 6 weeks of therapy, there is reduction in OSA severity and decreased adenoid size. And same thing with Montelukast, you can see that there are increased leukotriene receptors on tissues of patients with OSA. And there is a double-blind study that was done and also showed improvement in sleep disturbances. Now, when do you use oxygen in OSA? Because, in obstructive sleep apnea, that the primary etiology would be obstruction. So oxygen seemingly, does not make sense as a treatment. When you look at the recommendation for home oxygen therapy for children, which is a clinical practice guideline by ATS, sleep disordered breathing that is complicated by severe nocturnal hypoxemia in patients who cannot tolerate positive airway pressure or awaiting surgical treatment could, kind of qualify for home oxygen therapy as prescribed. But then again, this is a conditional recommendation and a very low quality evidence. Now, CPAP in children, the indications are those without any adenotonsillar hypertrophy or those with residual OSA after surgery. And if you are using your CPAP well, then it's linked to improvements in your cognitive performance. However, we know that adherence is extremely challenging in children. There are, some institutions that really have a program that desensitize them and make them get used to and tolerate CPAP. And it's also important to consider ramping up the pressure. That means that even if you have an optimal pressure for your overnight study, you start with a lower pressure and then work your way up that optimal pressure. Or you could consider the APAP, which is automatic positive airway pressure. So it depends actually on the need to open the airway, whether on your side position or on your supine position. You have like a selected pressure range, and that would actually automatically give the required pressure to open up the airway. Bariatric surgery, of course, after now in this epidemic of obesity, there are programs that are really, enrolling adolescents as candidate for bariatric program, and they undergo actually a process where they have nutrition and exercise counseling. Some of them might need CPAP, before their bariatric surgery, but after significant weight loss, their OSA also markedly decreased, with their apnea-hypopnea index significantly decreasing in one study, 9.1 to an AHI of less than 1. So bariatric surgery really reliably decreased weight in a sustainable fashion and really kind of corrects the comorbidities associated with your obesity. Does your program refer for rapid maxillary expansion? 70%. So this is really very encouraging. Through the years that I'm kind of polling about the use of palate expander or rapid maxillary expansion, now it is really recognized as really a to be considered as a treatment modality. The only challenging thing really now is for kind of access and insurance coverage. So let's talk about RME, rapid maxillary expansion. So this is really an orthodontic appliance that would deliver a lateral force to your upper posterior molars, and it opens up the mid-palatal suture. And so you have that window where it should be before, it closes, usually ideally before 18 years of age, to consider to widen the nasal cavity. So you can see that there's a key that the parent would kind of dial that opening there in order to kind of slowly open that up. So in terms of looking into the efficacy of RME, so you can see here in this diagram, this is a narrow palate. And after, usually it's about 4 to 6 months of expansion. And then after that, you wear retainers for another 2 months. You can see that the upper arch is wider, allowing for not just proper alignment of the teeth, but it decreases nasal resistance. It improves nasal airflow. It actually increases your oropharyngeal space and your maxillary arch so that it repositions your high-riding tongue. So it resolves that mouth breathing. And recently, there are a number, at least 3 or 4 meta-analysis of RME, and a good number of them. And usually they show a significant decrease in the AHI. So there's about 3 meta-analysis that I included in this slide. So actually in our center, we have a pediatric OSA group. We have a collaborative approach where the sleep specialist meets with the orthodontist as well as the oromaxillary facial surgeon on a monthly basis, and we discuss our cases. So with permission, this is one of our patients on the first visit. You can see they did a panoramic view of the airway. You can see a relatively crowded and high arch palate in here and the crowded teeth and kind of relative retrognathia. During the treatment process, you can see that, he was fitted with the palate expander 4 months into it. And then the retention is where he has to wear the retainers to allow bony growth. You see how if you compare the first visit to that of post-RME, what a difference. And it's not just kind of widening that space. As I mentioned, it actually decreases your airway resistance and it prevents your mouth breathing because of the proper positioning of your lung. As I mentioned, limitation of access to RME is because of poor insurance coverage, a lack of adequate screening and even referral. That's why that multidisciplinary collaborative approach is very important. I kind of left this cost analysis, but it's really very important because, when you look at CPAP and CPAP supplies over a number of years, would actually add up or even more. Usually the procedure for a palate expander or rapid maxillary expansion on average would be about tops $8,000. So it's a lot, of course, but if you look at how the insurance company would spend for the CPAP machine and CPAP supplies through the years, and it's actually, not a definitive treatment, there's cost analysis in there. So, hopefully we have kind of more awareness and more publications on this so that we can have like supporting literature to show for approval for third-party payers. Now, let's end with just talking about the evolving or other options, modalities of obstructive sleep apnea treatment. So does your sleep practice or program refer for myofunctional therapy? Yeah, good number don't know. Yeah, because this is relatively new, and what it is it's really a structured intervention where you have specific oropharyngeal exercises. So you improve your labial seal and lip tone, and then with that, you would kind of induce more nasal breathing and a favorable positioning of your tongue. So it's really kind of, if you see watch a video of it, it's rolling your tongue in and out or pushing it against a spoon, and also putting your tongue like here at both sides of your cheek. It's relatively easy to teach the patient, but you really need consistency and child cooperation and adherence. So, two ways to offset this is one, they can actually kind of have an appointment with a speech pathologist, so they kind of do it on a regular basis. And there's also what we call a passive myofunctional therapy, where they actually have a kind of an implanted device that kind of do this kind of exercises or stimulation. Now, another kind of evolving thing is the hypoglossal nerve stimulator. And this is also an implanted device that's electrically stimulating the hypoglossal nerve. So it causes tongue movement. So it is a device where when it senses that the tongue kind of collapse and obstruct the airway, then it actually stimulates the hypoglossal muscle. And this is timed to relieve that impending upper airway obstruction. So it's investigational in children, and it may have a role in Down syndrome and OSA. So in summary, the pathophysiology of OSA is really kind of honing into the mechanics and the balance between upper airway narrowing and increased airway collapsibility. So we talk about pediatric OSA. It's never simple. It's complex. It's a spectrum. And of course, there are many factors and variations that's interplaying with our patients. And now that there's really a lot of evolving options, we really have to look into kind of have a one-to-one assessment, kind of personalizing the treatment of your pediatric OSA. So who's a candidate for, adenotonsillectomy? Who's a candidate for the palate expander, and even have a role for, the mandibular distraction, and the last two, evolving things like the simple myofunctional therapy and that of the hypoglossal nerve stimulation. So that's the end of my talk.
All right, thank you very much. Thanks to everybody for sticking around for the end of our final talks. Please put any questions you have in the chat. Sorry about the sun behind me here. Dr. Kier, maybe while we're waiting, I might ask, what are you working on in terms of trying to get caught up after recovering from all the coronavirus? I presume your lab wasn't doing everything, and now are trying to go through the backlog.
Yeah, so we actually have been greatly affected. As you know, we have our pulmonary function lab, our trach patients, and our sleep centers. So we are actually kind of following the trend nationally. Our pulmonary function lab, we are so eager to start. However, our institution are still doing the air assessments. So we have some of our pulmonary function lab that have negative pressure room, but there are some who own that only has the HEPA filter. So how about you, DB, as far as the PFT lab?
Yeah, our PFT lab is open. We have some big enough space where we're able to spend some time in between patients to limit some of the exposure, but I'm not sure how our sleep lab is catching up since I'm not involved with that program there very much. Looks
So
like we do have one question in the chat from Amit Agrawal. He asks, what's the role of cutaneous CO2 and end-tidal CO2 measurements? I guess comparing how you would use them in sleep studies.
okay, so if I understand the question is, you know, when do you decide whether it's transcutaneous or it's end-tidal? Is that how I understand it?
Yep, that's what he was asking. Yes.
Yeah. So in younger patients who can't tolerate your nasal cannula, then you know, at least you have the transcutaneous as your form of measure for your CO2. In some cases, I actually have the luxury of kind of doing both the transcutaneous and the end-tidal if I have both available. And it's actually good to have both because you can kind of see the correlation. There are correlation studies out there, both in adults and the pediatric population. And if they are both properly functioning, they actually correlate. So either you have one or the other would be okay. Of course, for those you're titrating CPAP, then your only way would be your transcutaneous because you're already using your interface for your CPAP.
Okay. Thank you for it. Looks like that was answering the right questions. All right. It's just after 6 o'clock. Any other questions before we go? Again, thanks to the ATS Education Office for coordinating all of this. Thanks to all the fellows who stuck around. Thanks for the speakers, of course. I think maybe we will just sign off. Thanks again, Dr. Kier, for the talk.
Thank you so much, and thank you for being the closer of this game.
Yeah, no, thanks to you for being the closer. Thank you. All right. Thanks, everybody.
Have a good night. Have a good evening, everybody.